Needle Cricothyroidotomy. Needle cricothyroidotomy involves passing an over-the-needle catheter through the cricothyroid membrane. This procedure provides a temporary secure airway to oxygenate and ventilate a patient in severe respiratory distress, and is only used when other, less invasive methods have failed, such as a SAD or endotracheal intubation. Ancient Egyptian hieroglyphics indicate that surgeons may have performed this procedure thousands of years ago. This is an emergency procedure that is performed on patients in respiratory distress wherein you, as the care provider, cannot obtain a definitive airway via orotracheal or nasotracheal intubation. This is known as the can't intubate and can't oxygenate scenario. Clinical indications and reasons for not being able to obtain a definitive airway include a patient with difficult anatomy, such as an obese patient, or a patient with a large excess amount of secretions which are blocking the airway, as this would obstruct the care provider's view, or a physical blockage by a large mass or object. Contraindications for carrying out this procedure include tracheal transection, laryngotracheal disruption, retraction of the distal trachea into the mediastinum, a fractured larynx, pediatric patients under the age of 12, bleeding dysthesis, operator inexperience, and insertion site infection. Let's now take a closer look at the anatomy, starting with the larynx and the superior portion of the trachea. There are many structures in this area, but only a few you need to remember, such as the cricothyroid membrane, which is your main point of interest, as this is the membrane that you will puncture with your cannula, and it is tightly situated between the thyroid cartilage superiorly and the cricoid cartilage inferiorly. It's important to notice that these key structures lie midline within your patient, which is why your patient needs to be in a supine position, especially in an emergency situation, as there are other important structures immediately lateral surrounding the area which you need to be mindful of, such as nerves and blood vessels. Position the patient supine with good access to the base of the neck. Identify your landmarks. Palpate the thyroid cartilage, then the cricoid cartilage, followed by the area between them, which is known as the cricothyroid membrane. Clean site as per local guidance. Insert the 14-gauge cannula attached to the syringe filled with normal saline into the membrane at a downward 45-degree angle. When the catheter reaches the trachea, a distinct pop can be felt, and air bubbles will appear in the syringe. Safely remove both the needle and syringe and place the needle in Sharp's bin. Secure the 14-gauge cannula catheter to site. You need to connect your end-tidal CO2 to the bag valve mask along with a 3.0 connector, as it will allow the bag valve mask to connect to the end of the catheter. Some studies suggest a pediatric bag valve mask is better suited when ventilating during those procedures on an adult patient due to it providing a lower end tidal volume. However, it's best practice to use the BVM appropriate for the size of the patient. Be sure to also override the pop-up valve on the BVM, as it helps to prevent excessive pressure being generated in a small space within the catheter. As you can see on the adult BVM, this valve will pop up when excessive pressure is used. Be mindful that you are pushing air through a tiny catheter where you won't be able to deliver a huge tidal volume of air. But it is a last resort and better than nothing. If you don't secure the catheter in place correctly, it can cause a kink, which is why we use a 14-gauge cannula, as the catheter is less likely to kink and it can also help holding it in place. Remember, this procedure provides a working pressure of at least 103 kilopascals, which is approximately 15 psi, to allow sufficient oxygen through a 14-gauge catheter. This procedure is temporary at best. Translated, rapid, safe transport is imperative for a positive outcome. Subscribe to the channel for more.